The title of this talk is Neurodegenerative Disorders. The talk will be conducted using conversational and question and answer formats. These are the class objectives. You do not need to read them. We will use them to chart our talk. The first question is: a patient with Alzheimer's disease that can identify objects when presented individually but not when presented as a trio is likely to have dash involvement: A. Frontal lobe, B. Hippocampal, C. Superior parietal lobule, D. Occipital lobe. Alzheimer's disease was described by Dr. Alois Alzheimer. He described it in 1901 based on a patient named Auguste Deter. Alzheimer's disease, to which we will often refer to during this talk as AD, is a central nervous system degenerative disorder. It was classified as a central nervous system degenerative disorder in part because of the microscopic findings of plaques and tangles of unknown cause that were found in the autopsy of Auguste's brain. The autopsy was done 5 years after her symptoms of dementia had started. The outstanding characteristic of CNS degenerative diseases are that they affect a specific part or functional system of the central nervous system. The onset is insidious most of the time, usually after a long period of normal nervous system functioning, and the course tends to be gradually progressive. Classification of CNS degenerative disorders involving the brain vary from book to book. We will use the classification put forward in Principle of Neurology, but we will restrict ourselves in this talk to those entities with brain involvement and no significant spinal cord pathology. The only exception will be Friedreich's ataxia, to which we will refer to later in this talk. In Principle of Neurology, CNS degenerative diseases with the stated limits are classified as progressive dementia alone, progressive dementia with other neurological abnormalities, disorder of posture and movements, and progressive ataxia. Among this restricted classification, we are first going to talk about progressive dementia alone. In the group of progressive dementia alone, we have Alzheimer's disease, posterior cortical atrophy, which most neurologists consider a visual variant of AD, and frontotemporal dementia. We will talk about AD and its visual variant together because they are both considered to belong to a group of diseases called amyloidosis, and their clinical manifestation often blends. So the clinical manifestation of AD and variant can be bunched into 5 seminal findings. The first one is amnesia. Patients with AD may have instant recall problems, but usually problems with instant recall do not occur initially because most patients with AD at the onset of their disease have fairly good attention. Good attention is the main driver of good instant recall. So instant recall is not affected initially. Short-term memory is usually severely affected from the very beginning, often being the first manifestation of this condition. Long-term memory is also affected, but to a lesser degree than short-term memory, at least initially. The anatomical substrate for amnesia is bilateral hippocampal involvement. In this frame, you can see a normal coronal MRI. Notice the small size of the temporal horns of the lateral ventricles and the large masses of gray matter that constitute the hippocampus. I now introduce the MRI of a patient with Alzheimer's disease. Notice the large size of the temporal horns of the lateral ventricles and the small size of the hippocampus. This constellation, large temporal horns of the lateral ventricles and a small amount of gray tissue under them is the hallmark of hippocampal atrophy in MRI and one of the hallmarks of AD in general. The second seminal finding is dysnomia, that is, inability to name. Dysnomia first for proper names, then for common names. One way of testing for dysnomia is to ask the patient to name as many items as possible in a given category in 1 minute. Let's say we ask the patient to name as many vegetables as possible in 1 minute. Most normal people will be able to name more than 8 items. Patients with AD usually name 4 or 5, certainly less than 8. Dysnomia is related to diffuse cortical involvement. The third seminal finding is visuospatial disorientation, which can manifest by impaired facial recognition or prosopagnosia. I will give you an example. Prosopagnosia is the inability to recognize persons in picture or in flesh. Most people in the United States would be able to recognize this person. He was the first president of the United States, and his portrait is in the $1 bill. He's George Washington. Then, when some patients with AD are shown this picture and asked who is in it, they may answer mother. When asked to describe what they see, they may say long white hair or someone with a long nose. If asked if the picture is that of a man or a woman, they will answer man. Then, when asked who is the person in the picture, they may answer father. They have made the connection that a man cannot be their mother, but still cannot recognize who the man is. But if you ask who was the first president of the United States, they will answer George Washington, confirming that they had the knowledge of the historical character, but were unable to identify him by his facial features. Such finding indicates involvement of the bilateral temporo-occipital area, usually the fusiform gyrus, as indicated here. The fusiform gyrus is flanked by the collateral sulcus, medial to which you find anteriorly the parahippocampal gyrus and posteriorly the lingual gyrus. On the other side, you find the occipitotemporal sulcus, and lateral to it, the inferior temporal gyrus. In addition to prosopagnosia, patients with AD often get lost in familiar places, especially in late afternoon or evening. This phenomenon is often referred to as sundowning. They have difficulty setting a table for eating and often fail to identify the whole while being able to identify its part. This phenomenon, called simultagnosia, will be explained to you by giving you 2 examples. The first example is a patient with AD when asked what is this while pointing to the wheels of a bicycle, will answer wheel. And when pointing to the seat, the patient will also recognize it. The same when pointing to the pedal. In this situation, the patient will say pedal. But when asked for the name of the hole, the patient will say, I do not know. But then if given oral clues such as what do you ride has no motor and 2 wheels, the patient will say bicycle. In the office setting, what I do to test for simultagnosia is to show the patient a fork and ask what is it. Most patients with AD would recognize it. I do the same with a spoon and with a knife. Then I put the three objects together and ask the patient to take the knife. The patient with AD usually do not take the knife. Remember that the patient has a 1 to 3 chances of being right, so you may need to repeat the test more than 3 times, asking for different utensils. This type of abnormality is usually found in patients with bilateral superior parietal lobe pathology, which is a site of frequent involvement in patients with AD. This is a normal PET scan. Red means activity. Red and diffuse distribution of the color means good uptake of the isotope, indicating normal function. This is a PET scan of a patient with AD. Notice the lack of homogeneous distribution of the red color. Also notice the lack of red color in the superior parietal region on one side and on the other. This pattern of involvement can be detected by MRI. This frame has different MRI brain planes. Here in the sagittal plane, you can see significant atrophy of the mesial parietal region. Here in the transverse plane, you can see significant atrophy of the lateral superior parietal region. And also, you can see the same in this coronal view. I will now show you similar MRI views in a patient with AD visual variant. Notice the severe occipital lobe involvement in the sagittal view, in the transverse view, and in the coronal view. This frame has side by side the sagittal views of an MRI of a patient with Alzheimer's and a patient with visual variant. Notice the high degree of atrophic changes present in the occipital lobe of the patient with Alzheimer's visual variant when compared to the patient with the more common and prevalent type of Alzheimer's. Before leaving the subject of testing an AD, it is important to say that EEG in patients with AD are usually normal, especially early on in the course of the disease, because the cortical area most involved in patients with AD at this stage is the entorhinal area, an area not surveyed by EEG. The fourth seminal finding, frequently seen in patients with AD and variants, relate to paranoia and personality changes. AD patients may become convinced that relatives are stealing from them. They start rejecting all friends and make imprudent social and business decisions. This usually occurs with frontal lobe involvement, especially when the inferior surface of the frontal lobes are involved. The fifth seminal finding relates to executive dysfunction. Patients with AD and variant have difficulty coordinating and following through plans. They also have problems following complex conversations. At times, they complain of feeling confused, although most of the time they act confused, but themselves are not aware of being confused. This usually occurred late in the disease due to frontal lobe involvement. So the answer to this question is C. Next question. Which of the following is not usually found in the autopsy of patients with Alzheimer's disease? A. Seminal plaques. B. Fibrillary tangles. C. Irano bodies. D. Lewy bodies. We usually find 3 types of histological abnormalities in patients with Alzheimer's disease autopsy of the brain. The first one, as you can see in this colorful specimen, senile plaques are in the gray matter. Senile plaques consist of extracellular beta amyloid matter. Senile plaques are produced by abnormal cleaving of amyloid precursor protein. This process starts around vessels. Those produce amyloid angiopathy, which can lead to intracranial hemorrhage. In this specimen, you can see the brownish deposit in the walls of three vessels. For example, here, here, and here. These areas may lead to bleeding. The second histological finding is intracellular fibrillary tangles. They are made of clumps of paired helical filaments of hyperphosphorylated tau oligomers. The number of neurons so affected correlate with the degree of dementia. The third characteristic histological finding in patients with AD is found in the hippocampus. It consists of bodies. They are cytoplasmatic eosinophilic proteinaceous rods made of actin and actin-related proteins. This is another specimen showing bodies. I am showing it to you because at times, as the result of the location of the bodies in relation to the neuron's cytoplasm and the site of the cut for histological viewing, they look as if they were outside the neuron, but they are not. So the answer to this question is D. Next question. Which of the following substance is not found in large amount in the brain of patients with Alzheimer's disease? A. Tau, B. Beta amyloid, C. Actin, D. Alpha synuclein. Bodies contain actin and actin-related proteins. Senile plaques contain beta amyloid. Fibrillary tangle contain hyperphosphorylated tau oligomers. So the answer to this question is D. Next question. Normally functional tau has only one beneficial function. A. True, B. False. Tau stands for tubular associated unit. As you know, among the cytoskeletal structures here indicated by the aqua arrows, we have microfilaments made of actin. They are very numerous in the growth cones. Neurofilaments, the main skeletal component of neurons, and microtubules. Microtubules are also found in oligodendrocytes and to a lesser extent in microglia and astrocytes. Tau, that is normal tau, has 5 main functions in neurons. One is to stabilize microtubules. Think of tau as the cement that holds the units to form microtubules together. Second, tau contributes to neurite growth as represented here. Third one, tau helps in axonal transport, anterograde transport in conjunction with kinesin, and retrograde transport in conjunction with adenosine. This system transports organelles to most distal confines of the neurons and brings to the body of the neuron broken down organelles for recycling. Tau is also important for the transport of trophic signal enhancement. Trophic signal enhancement are biomolecules that support neuronal growth and survival. The fourth function is to be part of a cell signal transduction. Signal transduction refers to a transmission of molecular signal from a cell's exterior to the interior, where the signal ultimately triggers an action. Take a look at this animation. Notice the position of the tau protein. Now look at what happens when an extracellular element interacts with the receptor, as represented by the green triangle moving into the receptor. The tau protein dislodges from the receptor, traveling to another membrane-bound structure, and there it triggers a change in configuration of the element activating it. This activation produces a splitting of an adjacent compound, here represented by the light blue rectangles. The fifth function is heat shock cell protection. When exposed to heat, neurons with non-functional tau die before those with normal tau. So the answer to this question is false. Next question. Alzheimer's disease symptoms progress involving major vascular territories. A true, B false. This diagram depicts the course of neurons affected by Alzheimer's disease. This is a normal neuron with a central nucleus, dendrite full of spines making contact with incoming axons, and microtubules in the axon in perfect formation, with tau cementing the tubular elements. Here we have represented a neuron in the first stages of AD. Tau aggregates begin to appear in the body, represented by little dots, as you can see here. The axon begins to disintegrate and tau aggregates flow in the axon. It is important to appreciate what the arrow embedded in the drawing is indicating, probably being the most important point made in this drawing. This arrow indicates that the Alzheimer's pathology transmits from one cell to the next. Here you see a neuron with a nucleus to one side and the tangles occupying most of the cell body. Look at this dendrite and compare it with the normal dendrite on the normal cell. Notice that the spines are badly formed and the axons going to it are dying. Finally, the whole neuron is filled with tangles, and the axon no longer has microtubules. So going back to the model of transmission, we can say that Alzheimer's pathology transmits like a fungus in a tree. It spread from one leaf to the next and so on, as I have animated here. In the case of tau and Alzheimer's, tau goes from one neuron to the other neuron due to proximity. So the answer to this question is B. Next question. Lewy body disorders, including Parkinson's disease and DASH, are synucleinopathies. A. Pick's disease. B. Amyotrophic lateral sclerosis. C. Multiple system atrophy. D. Frontotemporal lobar degeneration. Alpha-synuclein is a protein produced by the scNA gene. Looking at the colors of the letters, you can tell what they stand for. The scNA gene is located on chromosome 4 Q22.1 locus. The function of the alpha-synuclein protein has not been unequivocally delineated, but it is believed to be important for Golgi apparatus functioning and for vesicle trafficking. When a mutation affects the scNA gene, an abnormal folded protein is produced. This protein is useless. The abnormal alpha-synuclein accumulates, and in addition, it will produce Golgi malfunction and vesicle trafficking malfunction. The accumulation of abnormal alpha-synuclein protein form Lewy bodies. They usually look like a round ball flanked by a clear halo. The brown material consists of neuromelanin deposit. The production of neuromelanin is driven by excess cytosolic catecholamine outside the synaptic vesicles. Neuromelanin has been shown to bind neurotoxic particles, including toxic metals, that, if not bound, promote neurodegeneration. It is unclear if the presence of neuromelanin past a given amount indicates pathology. Lewy body disorders, that is, those disorders produced by accumulation of alpha-synuclein, include Parkinson's disease, Lewy body dementia, and multiple system atrophy. In the talk about movement disorder, we spoke about multiple system atrophy. There, I had no time to show you a peculiar MRI finding that at times is found in patients with multiple system atrophy, so I will do so now. This peculiar finding is called the hot cross bun sign. It consists of a cross-shaped T2 hyperintensity within the pons, representing selective generation of pontocerebellar tracts. This frame shows a normal pons at the level of the previously shown MRI, and by the side a pons at a similar level with evidence of demyelination producing the MRI hot cross bun sign which I just mentioned to you. This finding is not pathognomonic for this condition, but is frequently found in it. So the answer to this question is C. Next question. Which of the following diseases is not a tauopathy? A. Pixie disease. B. Progressive supranuclear palsy. C. Corticobasal degeneration. D. Multiple system atrophy. Pixie disease affects the brain disproportionately. The frontal pole and the anterior region of the temporal lobe are severely affected. There is remarkable preservation of the precentral and postcentral gyra, most of the parietal lobe, and the occipital lobe, although affected, are less affected than the anterior frontal and temporal lobe regions. This can be readily seen in this MRI, as a disproportional frontal involvement is clearly noticed. Notice that the fullness of the frontal sulci and enlargement of the frontal horns of the lateral ventricles, as compared with the occipital horns of the lateral ventricles and the occipital sulci. PET scan in these patients demonstrate frontal hypoperfusion and temporal hypoperfusion. The term pixie disease is now often used to indicate frontotemporal degeneration, yet frontotemporal degeneration may occur in different pathological entities. One of these entities is associated with hyperphosphorylated tau, which is accompanied by pig bodies. Pig bodies are clumps of hyperphosphorylated tau. You can see here in a neuron stained with He looking like a swollen neuron. In the center, pushing the nucleus to the side, you can see a pig body. This is stained using tau. The pig body is more noticeable. They stain with tau because tau is the fundamental component of these bodies. Tauopathies include chronic traumatic encephalopathy, primary age-related tauopathy, pixie disease, progressive supranuclear palsy, and corticobasal degeneration. It is important to stress that certain diseases in whom tau accumulates are currently not classified as tauopathies. Most notably Alzheimer's disease, where you heard a few minutes ago tau is an important factor in its pathology, is currently classified as an amyloidosis. Parkinson's disease and Huntington disease also fall in this group. Frontotemporal degeneration also occurs due to abnormal TDP-43 accumulation. TDP-43 is a nuclear protein that functions in transcriptional repression modulating genes, splicing, and RNA metabolism. When TDP43 is abnormal, as in some cases of frontotemporal degeneration, the abnormal TDP43 forms ubiquitinated inclusion bodies in the cytoplasm, nucleus, and cell processes. Conditions considered TDP43 proteinopathies include frontotemporal lobar degeneration, TDP type, amyotrophic lateral sclerosis, and primary lateral sclerosis. So the answer to this question is D. Next question. Huntington's dementia can be classified as a progressive dementia with other neurological abnormality. A true, B false. In the classification put forward in Principle of Neurology, one major category is progressive dementia with other neurological abnormality. Among the conditions in this group, we have Huntington's chorea. Some features of this condition were discussed in the talk about movement disorders. Nevertheless, in this talk, I will stress some points. Huntington's chorea is an autosomal dominant condition. Tends to present in patients between 20 and 50 years of age, and is subject to anticipation, meaning it starts sooner and is worse in subsequent generations of affected families. Huntington's chorea is due to mutation in chromosome 4 at the P16.3 locus. In normal situations, the Huntington gene produces Huntington protein, a polyglutamate chain with less than 35 glutamines attached. This is so because a normal Huntington gene has formed from 6 to 35 CAG amino acid repeats. In adult Huntington disease, we usually find around 36 to 75 repeats, and in juvenile Huntington disease, usually a very aggressive form, we find from 48 to 121 repeats. So the answer to this question is A. Next question. NPTP, a contaminant in illegal drugs, is metabolized to MPP+, which is toxic to A. Red nucleus, B. Substantia nigra, C. Nucleus of Maynard, D. Subthalamic nucleus of Lewis. In 1983, it was reported that 4 young men developed Parkinson's after using illicit drug intravenously. 3 of the same authors 2 years later reported additional cases and confirmed that MPTP was a neurotoxin and that the damage produced by it were limited to the substantia nigra. This condition is not considered a neurodegenerative disease, but it opened the door to our understanding of Parkinson's disease. So the answer to this question is B. Next question. Which of the following condition is not a progressive ataxia? A. Friedreich ataxia, B. Horner syndrome, C. Holmes type of pure cerebral olivary atrophy, D. Machado-Joseph disease. The last group of CNS degenerative diseases consists of progressive ataxia. Progressive ataxias are classified in many different ways. One way is to use the mode of inheritance followed by a number. Another way is to use the area involved anatomically followed by a number. And another way is to use the type of presentation followed by a number. The numbers go up to 45 in some of these modalities. From a practical purpose perspective, I like to approach patients with progressive ataxia in whom I suspect progressive degenerative disease by considering the following points. Cause. Always consider treatable conditions first, regardless of how unlikely you feel the possibility is. Family history, present or absent. If present, then decide whether it's autosomal recessive or dominant or sex-linked. Course, smooth progression versus sudden deterioration or intermittency. Anatomical area producing the ataxia, nerves, spine, brainstem, cerebellum, cerebrum. Additional neurological findings such as spasticity, weakness, cranial nerve palsy, etc. And the presence of non-neurological findings. From an exam purpose, I will classify progressive ataxia using Victor and Adams' book. Progressive ataxia are classified in 3 groups: spinocerebellar ataxia, and in this group we have Friedreich's ataxia, cerebellar cortical ataxias, and in this group we will talk about Holmes' type of familiar pure cerebellar olivary atrophy, and a third group labeled complicated, hereditary, and sporadic cerebellar ataxias. In this group, we will mention Machado-Joseph disease. The diagnosis of a specific type of progressive ataxia relies on genetic testing. Usually there are panels that we can order when we suspect a specific type of progressive ataxia. So the answer to this question is B. Next question. Which of the following maneuvers test cerebellar function? A. Pronation and supination test. B. Wrist tapping test. C. The heel shin test. D. All of the above. Cerebellar testing can be performed using different maneuvers. Here I will mention 6 different maneuvers. The first one, the pronation and supination test for dystaxia and dysmetria of the hand. In this test, the arms are bent at the elbow and the patient is asked to pronate and supinate the hands. In this cartoon, I have portrayed the even excursion of the normal right hand and the uneven excursion of the ataxic left hand, indicated by the arrows. Second test, thigh tapping test for dystaxia and dysmetria. The patient is asked to flip one hand on the ipsilateral thigh. The patient with cerebellar pathology slaps irregularly and turns the hand too much or too little in alternately slapping the front and the back of his hands on his thigh. Third test, wrist tapping test. In this test, while the patient extends both arms, the examiner taps one arm as indicated here. In normal situations, no oscillation will occur. In the abnormal situation, you will see oscillations as indicated by the arrows in these frames. 4. The arm pulling test as indicated in this frame. Patient with cerebellar pathology may hit themselves in the face, so if you decide to do this test, be careful the patient does not hit his face. 5th, the finger to nose test. The patient is asked in this example to touch her nose and your finger. And the 6th, the heel to shin test. The patient is asked to trace the shin of the leg with the heel as shown here. Dysmetria will occur in patients with cerebellar problems when doing finger to nose and also heel to shin test. So the answer to this question is D. Next question. The cerebellum is only concerned with motor function. A true, B false. The cerebellum is a folded organ with 10 lobules. For the purpose of anatomical functional representation, the cerebellum is usually represented in an unfolded fashion. This unfolding occurs as demonstrated in this animation. The process can be compared to opening a book. The lobules are labeled numerically from the top to the bottom and correlated with the representation of cerebellum added here. I will now proceed with topographic anatomy of the cerebellum. This is an enlarged version of the prior cerebellar representation we saw in the prior frame. You do not need to know the name of every lobule, but I will mention a few. First, the lingula. The middle of the lobule 9 is called the uvula. 9 lateral is called tonsils. The appendages are called paraflocculus. The middle of 10 is called nodule. The lateral is called flocculus. The primary fissure is between 5 and 6 lobuli. The secondary fissure is between 8 and 9 lobuli. The posterolateral fissure between 9 and 10 lobuli. The cerebellum has 3 lobes. The anterior lobe in front of the primary fissure, it includes 1 to 5 lobules. Between the primary fissure and the posterolateral fissure, the posterior lobe. The posterior lobe includes lobules 6 to 9. 10 is the flocculonodular lobe. The vermis is the central region. The vermis, in recent studies, has been given, in addition to its contribution to motor coordination, a role in emotions. Flanking the vermis, we find the paravermis, and lateral to them are the hemispheres. The hemispheres appear to play a role in cognition. I will now make some comments about functional anatomy as it relates to its connection and correlated with the different lobes. The anterior lobe is considered the spinocerebellum. The spinocerebellum is anterior to the primary fissure. The primary function of the spinocerebellum is in coordination and rectification of movements from the body. The cerebrocerebellum corresponds to the area between lobule 6 and 9, between the primary fissure and the posterolateral fissure. The third division, based on connection, is the vestibulocerebellum. The vestibular cerebellum has to do with balance and eye movements, head movement coordination. It includes lobule 10. Some authors consider the vestibular cerebellum to include the uvula, tonsils, and paraflocculus together with the nodulus and the flocculus. For these authors, this is considered the archicerebellum. Other authors limit the vestibular cerebellum to the flocculonodal lobe, here in red, and consider lobule 9 as part of the cerebrocerebellum. The vestibular cerebellum has 3 unique features. 1. The vestibular cerebellum receives substantial amount of its input from the vestibular nerve. This is unique since no other portion of the cerebellum receives direct input from a sensory nerve. 2. There are connections from the vestibular nucleus to the vestibular cerebellum without going through any intermediary nucleus. And 3. Purkinje cells axons leave the cerebellum to synapse with the vestibular nuclear complex. This is the only instance that Purkinje cells do not contact with deep cerebellar nucleus neurons. These 3 points are important to remember for your exam. Now let's look inside the cerebellum. Were we to cut the cerebellum into an upper and lower half, as I have represented here, we would see 3 nuclei pair arrangements. The fastidial nucleus, that seems to be maximally connected with the vermis. A group of nuclei called interposed nuclei made of the emboliform and the globose nuclei mainly connected with the paravermis region, and the nucleus dentatus primarily involved with the lateral aspect of the hemispheres. The deep nuclei are the only significant output from the cerebellum, as the Purkinje cells are the only output from the cerebral cortex, with the exception listed while talking about the vestibular cerebellum. Efferent fibers to the cerebellum either directly or indirectly reach the Purkinje cells or the deep nuclei. So the answer to this question is B. Next question. Patients with Friedreich ataxia usually have signs of pyramidal involvement. A true, B false. We have already seen this table. I like to call your attention to spinocerebellar ataxias, and specifically to Friedreich ataxia. This condition was described by no other than Nicholas Friedrichs, a German pathologist and neurologist. There have been many theories through the years about the cause of Friedreich ataxia, but in reality it's all about fratacine. Good fratacine promotes iron-sulfur cluster enzyme activity. This is important for the functioning of the respiratory chain complexes and for the function of aconitase. These enzymes are involved in the control of reactive oxygen radicals. Fratacine is also important for heme biosynthesis and for mitochondrial iron balance, as you know. The use of oxygen allows the mitochondria to produce energy in the form of ATP, but the production of ATP has a consequence. The consequence is that reactive oxygen species are generated. These reactive oxygen species, if not disposed rapidly and efficiently, harm the mitochondria. The job of fratacine is to turn reactive oxygen species into harmless particles. Normally, fratacine is produced by the FSN gene on chromosome 9 Q21.11 locus. Normally, the gene at this locus has about 12 GAA trinucleotide repeats. When the number of repeats goes over 66 in both alleles, an autosomal recessive condition appears, called Friedreich ataxia. What is the mechanism of Friedreich ataxia? In the presence of good fratacine, iron in the mitochondria does not cluster and iron joins sulfur. This is important for the function of mitochondrial complexes 1, 2, and 3 and acotinase. All in all, the production of these substances in sufficient amount limits production and increases clearance of reactive oxygen species. In Friedreich ataxia, iron in the mitochondria clusters and does not join sulfur. Hence, the production and elimination of reactive oxygen species goes unchecked, leading to mitochondrial damage at selective places. Friedreich ataxia produces non-neurological and neurological problems. Non-neurological findings include diabetes, hypertrophic cardiomyopathy, scoliosis with very high degree of curvature, as you can see here, pes cavus, and hammer toe, to list a few. The neurological manifestations, as in previous condition in this talk, are better understood in relation to spinal pathology findings. This is a specimen of a patient that had Friedreich ataxia. You can see lots of affected fibers. These fibers are in the dorsal columns and in the dorsal spinal cerebellar tracts, producing ataxia. Loss of myelin fibers in the lateral corticospinal tract produces increased deep tendon reflexes and Babinski. In addition to tract involvement in Friedreich's ataxia, we find neuronal loss in the dorsal nuclei of Clarke, which we cannot see in this specimen. Lack of large neurons in the dorsal root ganglia, and poorly myelinated sensory nerve fibers. So the answer to this question is A. Next question. Familial cerebellar cortical ataxia, Holmes type, involves the brainstem but not the spinal cord. A true, B false. Now, back to the chart. I'd like to call your attention to cerebellar cortical ataxias, and specifically to Holmes type of familial pure cerebellar olivary ataxia. The olivary fibers are the source of the climbing fibers entering the cerebellum. The olive is atrophic in this condition. Neurological manifestations are ataxia, pendular but not increased deep tendon reflexes, and no Babinski. This is an MRI of a patient with autosomal dominant ataxia. It shows evidence of cerebellar atrophy. Notice the prominence of the sulci and the sparsity of parenchyma. Also notice that the anterior area located superiorly is more affected than the posterior area located inferiorly. The brainstem looks normal in this case, the expected olivary atrophy not being detected. The spinal cord is normal. So the answer to this question is true. Next question. Machado-Joseph disease, SCA3, only occurs in patients born in the Azores Islands. A true, B false. So back to the chart. The progressive ataxia group congregates many conditions. We could consider this group as a wastebasket or a holding bucket where ataxias not currently classified as spinocerebellar ataxia or cerebellar cortical ataxia are listed. Many diseases originally in this group, as the one we're about to describe, are now considered spinocerebellar ataxia, yet for historical reasons they are still lumped in this group. Machado-Joseph disease, although still classified in this group, as we have just mentioned, is also classified in the spinocerebellar ataxia group, as you can see in this frame. Machado-Joseph disease or spinocerebellar atrophy number 3 is an autosomal dominant condition. This condition was initially described in a family of Portuguese origin from the Azores Island. Hence, this condition is often referred to as Machado-Joseph Azores disease. Yet, Machado-Joseph disease is now widely spread around the world. It is estimated that it accounts for 25% of all patients with autosomal dominant ataxias. Machado-Joseph disease is due to expansion of the CAG repeat in the ATXN3 gene. This gene is in chromosome 14 at Q32.12 locus. In normal circumstances, it produces normal ataxin 3. Normal ataxin 3 cleaves the ubiquitin from unwanted proteins just before the proteins are degraded, so that ubiquitin is not degraded too and can be reused. Neurological manifestations may have an early onset. A significant number of patients start having symptoms in their 20s. Early symptoms are dysmetric horizontal and vertical saccades. Later, we find ataxia, brainstem findings such as otampoplegia and vulvar signs, extrapyramidal signs such as dystonia, and distal weakness. So the answer to this question is false. Thank you very much for your attention.